Well, good morning, everyone. Welcome to a cardiology / internal medicine grand rounds. And we're very pleased this morning to have Dr. Apte, who's an assistant professor in cardiology, which means that I'm going to have the introducer be Dr. Kalra, who is our chief of cardiology. It's been here now 2 years from Rush University, where we work together so closely. And Dr. Kalra, you can take it away.
Thank you, Dr. Williams, and good morning, everyone. It's my pleasure to introduce Dr. Nachiket Apte, who is in our division as an electrophysiologist and the director of EP at University of Louisville Hospital, as well as the program director of our EP fellowship. As you heard, he's an assistant professor in our division, has been here for about 3 years. He completed his medical school in Pune, India in 2007. And he then went on to do his residency in internal medicine at Johns Hopkins University Sinai Hospital, Baltimore. And that was followed by a fellowship in cardiology at Louisiana State University in Shreveport. And his EP fellowship was completed at the University of Kansas Health Sciences in 2020. Dr. Apte is a very prolific clinical electrophysiologist who works 12 hours a day at least, covers 3 hospitals, and has diverse clinical interests in atrial fibrillation, ventricular tachycardia, heart failure, and now, as you'll hear about today, the evolving field of how do we mimic our body's natural pacing system when implanting devices in people who need it. It's with great pleasure that I introduce Dr. Apte to talk about advances in cardiac pacing. Thank you.
Thanks a lot to Dr. Williams and Dr. Kalra, and good morning to all of you over here today. So, I would just spend a few minutes just reviewing, what is normal electrical activation and what is the current status of, devices for bradycardia and tachycardia indications. So, as we know, it's sinus node, which is the main sort of pacemaker in the heart, and the atria are activated from the sinus node with a cell-to-cell activation. All those signals end up in the AV node, and then there's a specialized conduction system, which we call as the bundle of His, which divides into the right bundle and the left bundle. And they then proceed down to the ventricular myocardial tissue via Purkinje fibers. So that's why your P wave is a broad P wave, while your QRS complex is a narrow complex because it is specialized conduction. So anytime that you have abnormalities anywhere in this circuit, that's where there is a role of a pacemaker. So that's why, you see patients who have both atrial and ventricular pacemakers leads, depending on their indications. So the ideal, pacemaker should be able to mimic this pattern. So the ideal atrial lead should actually, be positioned in such a way that it should actually mimic atrial activation, while the ideal ventricular lead to deliver what is called as physiological activation should mimic activation down the His bundle and result in a narrow QRS. Now, conventional leads are not at these sites. So that is why we say that they are not physiological. So, pacemakers currently are doing more than just pacing. We are just AV delays, basal rates, give a preferential heart rate depending on the patient's activity. We also provide prevent cardioinhibitory syncope in patients who have vasovagal episodes. They do respond to rate either with movement or with change in temperature, and that's why patients can actually speed their heart up depending on their level of activity. They can actually calculate patient activity. So we frequently have patients who we can track how active they are depending on what their pacemaker is showing. Of course, we know about cardiac resynchronization, which is essentially for patients who have heart failure. The goal being, activation of the LV and the RV to improve cardiac output. In certain devices, we can actually look at their fluid status, and outpatient management is possible by looking at how much, we can kind of track how much of thoracic fluid they have using their lead impedances. Remote monitoring has, especially in the times of COVID, has avoided the need for in-person checks. Patients have a monitor at home and they can essentially be transmitting their device checks as well as any episodes every few months, and avoid the need for an inpatient visit. And of course, event monitoring, where patients can actually send an event and it can be correlated with their symptoms. So the pacemakers also act as event monitors. More recently, in the last 2 or 3 years, for symptomatic heart failure who are not candidates for synchronization or who have failed it, we have modalities like cardiac contractility modulation, which essentially are thought to enhance contractility itself. So a conventional pacemaker, as we know, standard atrial lead and a ventricular lead. Atrial lead is placed in the right atrial appendage. That's the most common site. And ventricular lead is conventionally placed in the right ventricular apex for stability. Now, these sites are not physiological sites. They are just the most stable sites, because pacemaker leads in the past used to be passive leads, which had tines, and they would try to lock them in those chambers because the heart is moving all the time. So for stability, more than for physiology, those were the most common sites. So that leaves us with challenges. So of course, one is that there is a rate of periprocedural complications, including bleeding, hematoma, pneumothorax, etc. These leads are permanent. So even if we change the generator, the leads stay in the body. So with leads over 10 or 20 years, there's an increasing annual rate of lead malfunction, especially for older leads. Lead extraction continues to be the preferred procedure for patients who have bacteremia, which is persistent. It may not be available in all centers, and the patients may not be the best candidates. So there's always a risk of the infection and colonization of these transvenous leads. Tricuspid regurgitation has been estimated to be about 10 to 39%, depending on different studies, especially with the ventricular lead, where it traverses the tricuspid valve. Depending on its position, you can see moderate to severe TR in some cases. And then, of course, we are using a subclavian access for these leads. So for those who need access for chemo ports or AV fistulas or permanent lines, these leads need to be repositioned. So there are challenges with transvenous system, both in terms of access, size, and physiology. So there have been newer devices, and today we are going to only focus on 2 of them. So one is to mitigate the issue with size and number of leads. We have leadless pacemakers, which have come in, which are new. And then we have something called as conduction system pacing, which includes both pacing in the ventricle, but at the level of the His, and also at the level of the left bundle. We are going to focus on left bundle pacing in this session. So leadless pacemakers were first brought in about 10 years back, though the concept has been more than before that. And the earliest pacemakers were placed in 2013, which were catheter based and delivered from the femoral route because of its size. Where we left. We were talking about the options for leadless pacing, and this is one of the earlier trials, a prospective multi-control study for the Micra, the passive leadless pacemaker. It was mainly to look at safety and efficacy endpoints, and basically safety endpoints meaning stability and major complications, and the implantation was successful in about 90 to 99% patients. There were a few complications, actually, but 5 of them were significant, mainly pericardial effusion. And it was thought to be from RV perforation. So leadless pacemakers, they are essentially to be implanted into the RV septum. So over time, this has been recognized, and at least the registry data doesn't suggest increasing complications in that. And the efficacy endpoint was actually pretty good, with a 6-month, less than 2 volts at 0.24 milliseconds, which gives you a battery life of about 8 to 12 years. So it worked very well as far as efficacy was concerned. And this was the second leadless pacemaker. It is again, it is the active fixation leadless pacemaker, or the AVIR pacemaker, where again, safety and efficacy endpoints were met. Interestingly, for both of these devices, there were no dislodgements, which is always a big worry when you have a completely independent system in the heart. And they also had no device infections, which has also been found in post trial data as well, that compared to transvenous leads, essentially, rare episodes of device related infections. So they are designed to prove a leadless pacing option. So it's mainly for size and challenges with access. There is no reported cases in device trials, and that's likely because the device itself is small. The idea is that at least half of the 50% of the device actually endothelializes over the course of a year. So that could be the reason why there are no reported cases of infections. There have been some isolated cases that have been described, but nowhere compared to transvenous leads. The battery life is comparable to standard pacemakers, about 8 to 12 years for most devices. And of course, the most recent leadless pacemaker actually is a dual chamber leadless pacemaker. So, it is comparable to a conventional pacemaker. This is the Medtronic Micra, of which we have an atrioventricular option. So it has an accelerometer which is able to sense an atrial contraction, a mechanical signal, and then deliver an RV pace beat. So on the screen you can see that it actually has separate windows which can be programmed so as to time when it can sense a signal and then deliver a ventricular beat a few milliseconds after that signal. So there was a trial done for that as well in 2021, and it actually there was 70% AV synchrony at 100 beats a minute. So which is what I think is pretty impressive, given the fact that this is a mechanical signal that the device is using. The dual chamber option for leadless pacing was recently approved, and the trial was from 2023 June, where this actually has two leadless devices, one in the atrium and one in the ventricle. And the atrial device actually sends a 32-bit message through the blood, and with blood flow is able to deliver that to the ventricular lead. And then it can facilitate AV synchrony. It can also facilitate rate response. It can adjust AV delays. There was a trial that was done, that was just completed with 300 patients, where the safety endpoint at 3 months was actually met, and efficacy also was pretty good, adequate atrial capture at 3 months. And again, it was able to provide 70% AV synchrony in about 93% of patients. So this, we have our own experiences here. This is an 86-year-old man. And I would say for leadless pacing, the right patient would definitely benefit from that because of the intricacies in transvenous access. This is an 86-year-old patient with post-aortic valve surgery, tricuspid valve repair, mitral valve repair, and then in heart block in the 30s. So this is the delivery catheter going across the tricuspid valve, and with the leadless pacemaker at the tip there. We try to go higher in the septum, and I'll come to why we do that. But we see this is an extreme LAO view showing a more septal position, and this was able to provide AV synchrony at 70%, and somebody was 100% dependent. So we also know that lack of AV synchrony does cause symptoms, and with AV synchrony at 70%, this patient has been doing well since then. This is a challenging case. This was a 56-year-old man with a known ICD from 10 years, no other access available on the same side because his left subclavian was completely closed. Pacemaker dependent, and over the period of a year developed gradual RV and LV lead failure, and ultimately had a syncopal event and had intracranial hemorrhage. So he had all three at the same time. plus was being seen for a possible bypass because of new ischemia. So he had, because of lack of vascular access, we elected to put a Micra leadless pacemaker in this patient. And the existing device was actually programmed in such a way that his atrial lead was still kept active with rate response. And then the Micra would basically synchronize that and try to pace in the ventricle, so that we had two devices, one in the atrium, two separate devices, one in the atrium, one in the ventricle with AV synchrony. And again, at 3 months, it was more than 80% AV synchrony. Rate response was very good, up to 100 beats a minute, which is, I think, is pretty interesting. Yep. This is him. And you can see those other leads in the heart itself. So, adding more transvenous leads always causes challenges, and leadless pacing was a good option for him. So another challenging case, this was a 82-year-old man with permanent AFib, had an aortic root abscess, with progression, ultimately underwent, aortic root annuloplasty, had a tricuspid valve repair, and had a new aortic valve, of course, and then subsequently presented with complete heart block. And post-operatively, he was being placed epicardially, transfemoral route for a leadless pacemaker, and we could advance our wire in. So a contrast venogram showed that the IVC is completely obstructed with collaterals, forming going up to the right atrium. So no IVC flow. So we use the internal jugular access, and were able to, go across his tricuspid valve and then deliver it deep inside the right ventricle. So he has followed up in clinic. As you can see, this is the active fixation leadless pacemaker. They are the different from the, and then that is his final view. So again, he had permanent AFib and still is pacing 100% and doing well. So challenges, the cost, of course, it is 2 to 3 times that of a conventional pacemaker. So at least for the early pacemakers, they don't have any issues right now, but the more recent ones are still getting approved. So cost would be something that would, possibly be a hindrance. The delivery sheet is a large sheet. It's a 27 French sheet through the femoral vein. So for those with vascular accesses, it can be challenging. Given the size of the sheath, a lot of times they were requiring anesthesia for worry of pain and the fear of the patient moving in the procedure room. However, I would say that the device time is actually less than an hour, the procedure time. So at least at University Hospital, we have been doing them with moderate sedation, and results have been pretty good. The DR option, the dual chamber option, has recently received conditional approval. So it all depends on, MAC approval in some states. Some models don't have remote monitoring. So any additional technology is going to consume battery. So initial, models, the focus was to actually conserve battery. So some models don't have remote monitoring, and patients would still need to come to the clinic to get their devices checked. Longevity, in young patients would be an issue because, at least the stated battery longevity is about 8 to 12 years. That being said, multiple implantations would be the way to go, especially for passive leads. There's actually a study which showed that you could keep up to 3 to 4 of them in the human heart. This is a cadaveric heart, cadaveric RV, and you could be able to actually place at least 3 to 4 of them if needed. Higher chances of cardiac perforation but most likely from RV free wall implantation. And as I said, a lot of times conventional pacemakers would be placed in the RV apex, and all views may not actually show which is the real RV apex or RV free wall. With leadless pacing, now we are doing more LAO views, and these risks are less, though they have been seen in trials. Only one model currently paces the atrium. So for somebody like who has 6 sinus syndrome, for example, till recently, we did not have an atrial lead to pace. So It has just gotten approved, so that might change. And more importantly, which is a good segue to the next topic, which is that they do not provide physiological pacing. They can at most give AV synchrony, they can give backup RV pacing, they can give rate response, but these sites are not physiological. So it is an option for a conventional pacemaker, not for physiological pacing. So I wanted to mention this. Cardiac resynchronization is an important tool for treatment of heart failure, especially with a left bundle branch block. And there is a leadless option which is undergoing trials. So this is the WISE CRT device. It is a 1 centimeter leadless electrode which goes into the LV endocardium, and we also have a transmitter and a battery which is subcutaneous, and it synchronizes, like the transmitter synchronizes RV pacing. So you need to have a coexisting device, and then it delivers, it transmits ultrasound energy to this electrode to then deliver a pulse. So you have two devices providing RV and LV pacing. The trial is currently ongoing. So the next question, of course, is, can we have a completely leadless option where you have small leadless devices, providing cardiac resynchronization for heart failure? There's one case that has been shown, a completely leadless system. It was a case report. I thought it was very interesting. Maybe the sign of things to come. It's an 82-year-old who was pacemaker dependent, with a history of infections with existing leads. You also see an abandoned CS lead there because it's an old lead. So he underwent a simultaneous right-sided leadless and a left-sided, YCRT device, which was placed transeptally, and then underwent resynchronization, of course, with a pace QRS of 128 milliseconds, which is pretty close to normal. So a completely leadless option is not out of the picture. You might see that in a few years from now. So as far as physiological pacing is concerned, this is where we have the second topic. So conventionally, as we know, that right ventricular apical pacing has been the way to go, especially for stability of the lead. We also know that because it is not physiological, especially in those patients with a high pacing burden, right ventricular apical pacing is a major cause of pacing-induced cardiomyopathy. Now, over time, because there was a realization that we could actually put leads higher away from the apex. Increasingly over the years, RV leads have been attempted to be placed in the RV septum. As we know that trabeculations are where these leads are attached, screwed in with active fixation, and we do have septal trabeculation, so that could be a site for stability. So they have been attempted to decrease pacing-induced cardiomyopathy. This is, from RV pacing only, and we can see that with RV pacing, there is mechanical dysynchrony. The septum of the LV actually contracts first, followed by the lateral wall, given that electrical activation is septal to lateral. So there is dysynchrony. As you can see on the image on the right side, there is a delay from septal to lateral activation. So this causes dysynchrony, which ultimately ends up in pacing-induced cardiomyopathy. So, septal pacing has been attempted. I would say it is the more physiological of the two, and thought to result in a narrow QRS. It may cause lesser LV dysynchrony, but it is not completely out because the QRS still remains wide. The current practice right now is to avoid RV apical pacing and go for a more septal lead. But it still may be responsible for LV dysynchrony. It is not completely preventable. There have been, reviews and trials of these where RV apical pacing has been compared to septal pacing, and though in patients, who had non-apical pacing, they had better ejection fractions, there was no benefit in terms of survival, function, quality of life, and of course from clinical experience, we do know that they still get pacing-induced cardiomyopathy. So, physiological activation is what you would desire. And currently we have two options for that. One, of course, is cardiac resynchronization, where you actually add an LV lead. It's an epicardial lead, but it goes in through a branch of the coronary sinus into a lateral vein. And currently it has robust trial data. And for those patients who have heart failure and those who have an expected RV pacing of more than 40%, those patients are getting 3 leads in the heart at least, one for the atrium and 2 in the ventricle. This is already established. So that's how, they look on the X-ray with 3 leads. Limitations. So with with this device, you have to have a vein to actually put that lead in. Thresholds may increase over time, leading to more battery changes. Not all left bundles are the same. You have to have a left bundle to do this. Not all RV pacing is the same. And again, this is not physiological, though it does narrow the QRS. So then we come to what is called as his bundle pacing. And again, this has been out for some time. This focuses on actually trying to put the right ventricular lead into the bundle of His. So you actually screw in the lead deep inside the RV septum and also high in the septum and try to capture the lead, try to capture the bundle of His. The capture can be selective in the His, or it can actually capture the His and the RV. So it is also called as non-selective capture. This already has an indication. It's a class 2A for those patients who, of course, have an EF between 36 to 50% and are expected to have more than 40% pacing. So again, desirable because it's completely physiological. So that's how the lead looks. It's high in the septum, and this is a thin lead which has been screwed inside the His. The concept was described in the 1970s, but it was first implanted in 2000. More than 10 years of data, mostly observational studies, but definitely promising. And this is how the QRS would look. This is intrinsic activation with a narrow QRS. Of course, it can be broad in patients who have an existing left bundle branch block. And RV pacing and BiV pacing, though they can change the QRS, it is not physiological, while his bundle actually can reduce it to be completely narrow in any type of QRS. So, and of course, there are improvements in QRS duration over time as well. So this we already know. The issue is that there's a significant operator curve. We are observing the lead under fluoroscopy, so that adds to the time. The His region is pretty small. It's a very small area to actually capture and then deliver selective capture. The thresholds increase over time, unfortunately. We know this because over and over, we are trying to capture a very small area. There's a higher chance for generator replacements. Currently, only 1 lead has been FDA approved, and there are just 2 sheets that have been used in most studies. So we don't have much data to go by for other devices. What happens if there is block beyond the His, and if the patient doesn't have any backup pacing? So there was a time when patients would get 3 leads, 1 for backup and 1 for His. But again, we are adding more leads, and that is always an issue. And of course, there is no substantial data on lead extraction in this situation because this is a deep lead. It's a lumenless lead. So we are actually pulling the lead with extraction. There's not much data on that. So that's where other options were looked at, and one of them, of course, which I'm going to talk about, is left bundle area pacing or left bundle branch block pacing. So this involves placing the same lead just below the His, but deeper in the septum, in order to capture the left bundle branch. So, as you can see in this diagram, in this picture, the lead is beyond the His region, and it is deeper in the septum in order to get to the LV side of the septum. So, this is just a gross picture. But you can see that the bundle of is actually a very small region, but the left bundle is almost 2 to 3 times that. So given this size, we have more length to work with left bundle leads compared to a standard His lead. So I'm going to just mention some terms. So His bundle pacing being where you have a distinct His signal and there's simultaneous activation, which is physiological. And of course, left bundle area pacing, which includes left ventricular septal pacing, which is just the LV septum, as well as left bundle branch placing, where you have selective activation of the bundle branch and its sub branches. So given all these options in the same area, we now have many options to put our leads, which includes selective versus non-selective left bundle, left septal, simultaneous capture of the entire septum with anodal capture, mid septal capture, and of course his bundle pacing. So we from a conventional apical pacemaker, now we have a few options that we can use depending on the patient. So you know, it's the most commonly used is the luminless lead, which is directly put in through a sheath. There are deflectable sheets as well, depending on the anatomy. All 12 leads are used, and we actually have an EP recording system to look at the current of injury and measure these times. So measuring the time of activation to the LV is critical to getting the right spot. This is a fluoro image in LAO, where you can see that the sheath is actually on the RV septum, and we are putting contrast to light up the septum. Then you can advance the lead. You identify the His signal. Now in conventional His bundle pacing, you would directly put a lead there, but in left bundle pacing, you actually go beyond the His. You go distal to the His and move ventricular. And with 6 or 8 slow turns, you measure what is called as impedance. And when we get the right site and capture the left bundle, the sheath is then peeled away. So this is another picture here. So you can see that his lead is definitely higher and the left bundle lead is deeper. And you can see contrast coming out from the sheath there, and it is lighting up the septum. So you can see that the ring of the lead is actually deeper in the septum. So the target site is about 1.5 centimeters below the His, and pace mapping does help during the procedure. So there are different sheets available depending on the shape of the septum and the shape of the tricuspid valve as well, because it goes right below the tricuspid valve. The lead is the same. It's a luminless lead with active fixation. There other vendors have now come out with what are called as stylet driven leads, and they essentially have the same function. So you'll have other vendors with their own options as well. This is what I wanted to focus on. So as we are delivering the lead into the RV septum, we can follow the QRS and follow impedance to know how deep we are going. So if you focus on V1, as you see that the deeper the lead goes, you start seeing a small R wave in V1. And as it goes deeper and starts capturing the LV septum, so here is from the RV, goes to the LV septum, you start getting a narrower QRS with a terminal R wave deflection, which is slow. And when you enter the left bundle, you actually see a more narrowed QRS. You may actually see a left bundle potential. And the QRS definitely narrows compared to the previous sites. So then you know that you are in the left bundle area. Now here, pacing capture can be selective or non-selective, but at least you are in the site of interest. So just to give an example, this is a 72-year-old man, with symptomatic bradycardia, chronotropic incompetence, frequent pauses. And this is the sheath in the septal view, which is lighting up the septum. And then we deliver the lead, and as you can see, contrast, which is lighting up, so it's lighting up the septum. So you can see that the lead tip and the ring are inside the septum. So it's a deep implantation of the lead, and that's how it looks. There's another patient with intermittent heart block. We went for a higher site, but it was abandoned after the thresholds were high. So you have an option for a lower site now in the septum, as you can see. And there we have the lead in the deep inside the septum and capturing the left bundle as confirmed. So, because it's a new technique, there are different criteria to know which is appropriate left bundle pacing. And these are the following ones, which I'm going to talk about, a few of them. So pace QRS morphology, you should see a QR pattern or at least a small R for classical selective left bundle branch block pacing. Septal pacing, where you're just capturing the LV myocardium, may have a slightly longer QRS, but you should still be able to see a small R wave. in the QRS in V1. So this is typical, and that would tell you how deep you are in the septum. Another option is to do what is called as activation time. Basically, like the time it takes for the signal to reach from the septum to the lateral left ventricle. The shorter the time, the more fast is the activation. And usually less than 80 milliseconds is indicative of bundle capture. So average QRSs in left bundle leads are within 120 milliseconds. They may not be the same as his bundle leads, but they are very comparable. And it should be demonstrated across different outputs so that you can demonstrate that you will conserve battery even at low outputs here. Sometimes you can see a distinct potential at the site, and it is actually a left bundle potential. So that can be seen. The depth of implantation is a good guide on fluoroscopy. You go up to 1.5 centimeters in the septum, so you need to know what is the septal thickness for that patient under echo. This is how it looks under CT, where you see the tip and the ring deep inside the RV septum, in the interventricular septum. This was the first case described in 2017, so it is a very new technique where this patient, 72-year-old, with heart failure, typical left bundle branch block, failed CRT, which is conventional, attempted his bundle where the thresholds were very high and the left bundle was not corrected. But the left bundle with the lead was actually advanced, more distal and more ventricular. And at 1 year follow-up, the EF increased to 62%, and diastolic volume from 76 to 42 millimeters, and definitely improvement in NYHA class. So this was the first case described about 6 years back, and since then it has definitely caught on. Also, it's just like a conventional dual chamber pacemaker. You can adjust the AV delays to ensure that the left bundle is captured preferentially. So the idea is that if the left bundle is captured, it might actually overcome existing AV delays, existing AV block, and still be able to deliver a narrow QRS. So this is an example of a conventional dual chamber pacemaker with wide QRS, and this is what you would see with a left bundle lead, where you see a terminal R wave in V1 and definitely a narrowed QRS. So this is another example. This is a 35-year-old woman with tricuspid valve endocarditis, underwent valve surgery, followed by complete heart block. So complete heart block in a patient who is 35 with no good options for physiological pacing. We opted for left bundle pacing, and this is the result after lead placement. This is another example. Again, you can see a terminal R wave. This is again a 32-year-old woman with valve surgery. There have been studies to compare septal pacing versus bundle pacing. They are not the same technically, but do they actually mean anything different? So this is a small study done where they found that there was not much difference in heart function. So we still don't know whether it's a small study, but we still don't know whether that delay in activation time from septal to bundle actually has an effect on the ejection fraction. This was another study attempted, very interesting concept. They actually paced the tip and the ring separately. So the ring, was capturing the RV and the tip was capturing the LV separately. And they looked at delay in activation time. And they found that with selective left bundle, actually they were separate. With left bundle pacing, there was synchronization that was shown. There are only 2 trials that have been done so far, and they are all small trials which have shown benefit of left bundle and his bundle over biventricular pacing. As far as heart failure is concerned, as far as AV block is concerned, most techniques for left bundle are just latching on to his bundle pacing trials and studies. There are no direct trials which compare his bundle to left bundle. And I can completely understand that, because the region is so small that you may be actually in the same vicinity when you are capturing. I would say left bundle is probably more deeper, of course. But this is one of them. This is called as the hot CRT, which compared his bundle pacing to a conventional CRT in patients with EF of less than 50%. And they found that the increase in EF was present in both, but it was higher for those with his bundle pacing compared to BIV pacing. A small trial, 50 patients each. This is another study. This is an observational data, actually, more than 1,500 patients. It's a big registry for left bundle pacing where they compared it to BIV pacing. And they found that the QRS was definitely narrower in left bundle pacing, 128. The EF improved in both groups, CRT as well as left bundle, but it was greater for left bundle pacing versus BIV pacing. So this is another study which I thought was interesting, small study, but they look at early left bundle pacing. So in patients who had a mildly reduced heart function, but had a left bundle, would they benefit from early pacing? So they were, you had about 42 odd patients who were randomized, and they just, sorry, they were not randomized, but they were divided into two groups, one which only had left bundle and the other group had left bundle along with other comorbidities, including scar in the including cardiac scar. And they found that with those who had the left bundle branch block only, more patients there experience increase in heart function. So it is a risk factor that can be mitigated with left bundle pacing. This is the first randomized trial, again a short trial, which compared left bundle branch block with biventricular pacing, and it did show again higher improvement in heart function compared to BIV pacing. This is a trial which is to be started. It is going to be a huge multi-center trial with about 2,000 patients, which are comparing, it's called as a left versus left, but it's comparing his or left bundle pacing with biventricular pacing in patients who have heart failure and have anticipated 40% burden. And of course, primary objective being all-cause death and heart failure hospitalization. So pretty significant. It's supposed to start sometime next year and would take at least 3 years for follow-up after the last patient. So challenges. So there's no long-term data from trials. Most of them is from registries. Heart failure, we don't have no long-term data to compare. We have that one trial which is supposed to start. No longer on lead extractions. These are sturdy leads. These actually were used in pediatric patients. So there is experience with using them, not experience with extracting them. Revising a bundle is challenging because we need a sheath to actually get to the site. So frequently you need a repeat access and then use the lead. You cannot just open and repush in the lead. We talked about LV desynchrony with RV pacing. What happens to RV activation with left bundle pacing? Again, there is no large data on this. I would say that there should be desynchrony of the RV with capture the left bundle. But what does it mean in the long term? We don't have any idea of that. Of course, there is time and training needed, but I would say that it is definitely lesser than his bundle because the area to put your lead is larger. Of course, any issues that conventional leads have will be faced by these leads as well. This is an interesting study that I thought would be something to look at. So what the authors here have done is they have compared desynchrony with pacing from the left bundle and the left septal. So the markers in red are from the septum, and the markers in green are from the bundle, non-selected. The markers in blue are from his bundle pacing. And the farther you go from the vertical, the interrupted line, the more desynchrony you have. So as you can see, that left bundle pacing has more, interventricular desynchrony. His is, of course, is very closer to the midline, while septal pacing, LV septal pacing doesn't have as much. So left bundle pacing will increase interventricular dysynchrony. Now, whether that actually means anything in the future, we don't have, but we have evidence that there is dysynchrony as well. There's a slightly higher rate of lead dislodgements in initial studies. You do selective versus non-selective capture at implant, but it may not be reflected. I would say that compared to his bundle, non-selective LV capture may not actually be an issue. It hasn't been an issue so far, but we don't have to see that in trials. What happens if you keep burying inside the septum? So at some point, you will see a loss in capture, you'll see a loss in impedance, and that is a sign of LV endocardial perforation. Now, this has been seen in registry data. Fortunately, in most of those patients, the lead was taken back into the septum and there were no immediate effects. There have been some rare cases of late perforation. Anytime you have a lead in the heart, it is going to be prone to thrombus formation. So how deep to go in the septum also needs to be studied. You have a wider area for implantation, so you can have different morphology. So there is no standardization that we can actually look at this time. With more leads, you can always have lead interaction. So that is always an issue. What if you combine an ICD lead with a left bundle option? So you would get a left bundle lead, which is also can function as a defibrillator. So there is a lead that has been out, but there is a trial that is hopefully going to come out. Of course, there's concern because we are trying to have two functions in the same lead. So that would have to see whether both functions, defibrillation as well as pacing, can be delivered by the same lead. What happens if you combine leadless pacing with left bundle? So this is an X-ray of a patient with the pacemaker, the leadless pacemaker actually high in the septum, and this is a patient with complete heart block with slow escape, who's now having AV synchrony from a leadless pacemaker. The QRS is narrow, and this is a confirmed 100% capture. So you always wonder, did the leadless pacemaker actually capture a conducting system? Now again, can this be possible? Current devices don't have that. We have passive leads who cannot achieve the depth. Active fixation leadless pacemakers can potentially do that, but there is concern for TR if you are so high in the tricuspid valve. This is a study where they looked at heart failure and right bundle branch block pacing. So a little different, small group of patients, about 120 patients, where left bundle pacing actually narrowed the QRS. Slightly not as great, but EF also actually slightly got better. And the thought is that with left bundle pacing, the ring is actually capturing the interventricular septum, so delivering a more physiological response compared to just pure right bundle branch block. So that could possibly result. Again, it's a small study, so more studies are needed. This year, we actually had a guideline on physiological pacing, which includes both his and left bundle. And this is the gist of it, where sinus pacing remains guideline proven, but while data for his and left bundle is mostly observational. For those patients where RV pacing is less than 40%, you can still opt for conventional RV pacing, where the burden is not as high. But for those where it is high and there's a risk of pacing-induced cardiomyopathy, you would prefer physiological pacing. So now it gets a class 2A indication when you cannot achieve effective CRT, and a 2B indication for patients who have a low normal heart function where you are expecting higher pacing-induced cardiomyopathy. So this is, we expect, high ventricular pacing, and CRT is not an option. You can use either his bundle or left bundle pacing with a class 2A and a class 2B indication depending on the heart function. So, just to summarize, left bundle branch block pacing remains a great alternative where CS pacing or his bundle pacing are not possible. Selective or non-selective left bundle pacing manages to keep the QRS narrow, has grown great promise, but long-term data and randomized studies are needed for more robust recommendations. And, it needs to be merged with newer tools to reduce hardware in the cardiac chambers while delivering physiological pacing. So, I just end this with this slide. So, we are used to seeing a paced EKG like this, and this has been the norm for many years. And would you rather look at it like this, where the QRS, a paced QRS, is actually a narrow QRS delivering close to physiological pacing and still being able to be stable and have good battery life? Okay. Thank you. Thank you so much.
Thank you. That's really wonderful. Big question, of course, is how about the leadless defibrillator? So we heard about this about 2 years ago. It would be really fantastic if we could do that, but I don't know.
There are currently two models that are that one of them is already in use. It is so the defibrillator requires a bigger battery. It is a different function. It has to deliver a high power to actually deliver that shock. So current models are all big and they would be subcutaneous. I think the earliest we can expect is a non-intracardiac defibrillator. So a subcutaneous or a which Medtronic is actually coming out with what is called as the EV, an extravascular defibrillator, where the lead is outside the heart but inside the chest with the defibrillator, which is again in the axillary region. So that's what we know. I feel that those are two different functions, and the initial way would be out the heart is inside the heart, where you need to conserve battery. So that would be an interesting. I think the completely leadless option with the subcutaneous defibrillator and a leadless pacemaker delivering physiological pacing would be the ideal way to actually for anybody who has a bradycardia indication as well.
Right. Yeah, it looked promising from Cleveland Clinic, but 2 years ago, but they were not putting in leadless hip bundle or left bundle pacing, and then having this, it looks like a subcutaneous left axillary with a wire going up the chest to drive it. But hopefully that'll develop.
You correctly pointed out all the difficulties with implanting leads or leadless pacemakers in different portions of the conduction system. I think what I'm looking at in the future is so right now we don't have data on functional outcomes, right? You have some data on 3-point improvement in ejection fraction. The QRS looks more beautiful, but patients don't care about that. They want to exercise better, feel better, have greater longevity, and survive. So that data is still being awaited. But if I look into this, and I want to get your comments and thoughts about this. Do you think the future will be implanting tiny beads acoustically activated by an external source of power rather than having a battery inside the heart? Lots of hardware. You're talking about 3 or 4 different leads. Do you think we'll get there, or biological reprogramming of cells to take up pacemaker activity? Because the way I see this is not sustainable. Like have 3 different leads going in different places, hardware, infections, thrombosis, changes. I don't think this is what people want 25 years from now.
No. I think if I look at the next 5 to 10 years, I see miniaturization of existing therapies. So I do see, leadless therapies. I do see, as you said, maybe even smaller beads who just need activation, but the entire circuitry for it is going to be outside the heart for sure. 25 years, hopefully we have solutions, with stem cells, maybe regenerating AV node and bundle cells, and also sinus cells, hopefully, in which case we don't have to anymore start putting hardware in the heart. So 25 years down the line, that could be an option, definitely. So I think that remains to be seen. I think the immediate future probably is small. Hopefully 25 years down the line, it's no devices in the heart. That could be the ideal solution.
So Jason, I'm looking for any more questions.
Nothing
in the chat.
Nothing online today.
All right. Well, thank you very much.
Thank you.
It's been very informative. There's great technology, and looking forward to even further development.
Thank you so much.
Thank you so much.